Okay, welcome everybody to our annual alumni update for 2022. We still, I guess, waiting for people to sign on, but we might as well get started. We don't want to keep the others waiting. So, again, as you all know, we've completed a second year under COVID. They were doing new Chiefs pictures, and this is one of the photos that they came up with. We're still masked and gowned and have all the protective equipment that we need. Unfortunately, we've lost a lot of people. These are flags for all the people lost during the pandemic, and obviously this is continuing to rise because this was late last year, 2021. So, it's unfortunate. We'll remember these years as to the incidents that are going on. Unfortunately, we haven't lost anybody on the dental service, but we lost two friends of the dental service. Dr. Elliott Strong passed away just before Christmas at the age of 95. And our friend, Dr. Turnbull, passed away a couple of weeks ago. He was predeceased by his wife. So two friends of the dental service are no longer with us. The other thing I'll have to put my 2 cents in as the first Ukrainian American chief of the dental service. We were at the Metropolitan Opera for a concert for Ukraine. And obviously, there have been a lot of protests and rallies. So just pray for peace. So coming to today's agenda, we have, as our tradition goes, we have two former fellows presenting. So we have a recent graduate and a not so recent graduate. So Lydia Legg, maxillofacial prosthetics class of 2020. And Ryan Lee, dental oncology class of 2012, will be presenting. We'll have a short break for the question and answer period, and then have case presentations by our current fellows in dental oncology, maxillofacial pros, and our research fellow as well. So without further ado, we're going to present Dr. Legg. Dr. Lee will join us later. And again, Isabel Pennings and Kedanik Tawaldi, class of 22 dental oncology. Anthony Farmer and Harrison Spatz, maxillofacial prosthetics class of 22. And our research fellow, who is actually joining us from India. And so she will be online with us as well. So I'll stop sharing here. Lydia, take it away.
So first of all, just wanted to say hello and introduce myself to those I don't know. I can't wait until we can actually, meet in person again. And my time at Memorial was incredible and very memorable, as you'll see. So thank you, Dr. Huryn and Dr. Yam, for the invitation to speak today. And I was going to kind of go over, trying to figure out what to really speak on. And I was going to do some cases and things like that. But I really, as I was going through 2 nights ago, when I was going through some of my photos that I was going to put up of our class, I started going through the year and really, I don't know, I hope this is okay, but I wanted to kind of go over the year that we had because we were, I guess I'm officially naming us, let's see here. We're the class of 2020, or as you call us, also known as the COVID crew. So this year, that year that we had was just, it was unlike anything. It's really left a mark on me personally. Just with, I feel like we went through that year a different experience than we would have gone in any other, had we been in any other institution, because we were at ground zero there in New York City. So I'm going to try to just go a little fast because I just, I was going through it. I thought it was just an incredible time and a very trying time for everyone. So just wanting to reflect on that. This was our first day. Starting out, I literally came home and that's like, after being in the clinic, as everyone knows, it's a really slow clinic and there's not much happening. And after my first day, I came home and I was like, I don't know if I can do this. It was just, everything. It was so intense. And afterwards, after a few weeks, you kind of get into the routine. And then when you look back on it, you're like, how did we even do this? Just the schedule that we had and just all the things we were juggling, but I wouldn't trade it for anything. So in 2019, we started out in July. There's the four of us. Dr. Petty was our guinea pig. We had Dr. Habib and Dr. Singh and myself, and Dr. Cortez, who started out with us in the service. So, we started out, it was a typical year, starting with the summer doing our maxillofacial moulages, spending some time together, trying to get to know each other with some good food. And this is also Dr. Ahmed here in the forefront, who was our Dr. Rosen's research fellow. And then Dr. Ferris, who is on the right here, I believe he's has gone on to periodontal residency at the VA, I believe, there in Manhattan. So we went to the AMP, we all presented, Dr. Habib and I, Dr. Rosen and Dr. Huryn, of course, were some of the moderators. And so, great time starting out here. And, this is when we were still able to have our lectures. Our tumor board was in the main auditorium. We were able to hug each other. We were even able to shake each other's hands and just kind of going about our business. But some things started happening other than COVID. So while we were there, Dr. Rendezzo and I were in the OR. I remember us getting a call from downstairs saying that the clinic is flooded. And so this really shut down the clinic. All patients were in the chair, and I'm sure Dr. Huryn could elaborate, but patients were in the chair and we had a flood. So the clinic was shut down, the lab was shut down for a while. Everything had to be cleaned and dried. So went on through, we had our Christmas vacation. We got a chance to, sit down with everyone. We had different types of foods, was able to do a Secret Santa, and just a great time. We're all together and, just making it, surviving our fellowship year. And then we also had, who can forget the listeria outbreak in the cafeteria, which was a staple for most of us. This was something also very crazy that happened during the year that we were there. And also Robert, who was, our reliable, crunch time implant guy, he actually had an accident and was out for some period of time. But then, things started looking up. It was a new year. We had, in February, it was the opening of the Cope Clinic, the Cope building. We were just kind of admiring the night before. It's an incredible facility. If you haven't had a chance to visit yet, 16th floor is the dental service. But, it was just a beautiful, beautiful clinic, kiosk, great patient waiting room. This was our crew the first day of opening with over at the Coke building. So in the middle here you can see it's kind of like a lounge area, so it's just an incredible place. Really nice operatories, brand new equipment for the extraoral prosthesis and for Marge. And a brand new lab, brand new sterilization. It was just a really incredible time. This was February. It actually, this opened right before COVID. And I remember this day sitting in the break room with Dr. Estillo and Dr. Petty. And Dr. Estillo was telling us that there's this virus that's coming, and they think that it's going to change the way that, it's going to change the way that we live forever. And there was a rumor that the mayor was going to shut down the city in the fall, the coming weekend, and that we would need to get some money, get some cash. And, Alice and I were sitting around thinking like, well, how much cash do we need? Like, what is happening? And I remember thinking like, Dr. Stillo, I was told her, I was like, this is not good. How's it going to change our lives? Like, it's a virus, like maybe a couple of weeks, we can cancel some cases. We've got a couple of fibula cases coming out. And so, March 15th came, and as everyone knows, it affected everything of our living. New York City, every place in the world became closed. And so this was actually, I lived in the fellows building adjacent to the hospital. Dr. Habib and I both stayed there. And so we were able, in my view, I was able to have a straight shot to New York Presbyterian. So every night, we were able to see this kind of parade happening, and listen to Frank Sinatra, and just kind of supporting everyone, the whole city. It was an incredible place to be at this time. Like, everyone was supporting at 7:00 every day. But it kind of became really eerie in the hospital. We're starting to see stuff like this where all throughout the hospital, we're seeing, these signs, please stand here. We're learning new terms about social distancing. We were seeing these refrigerated trucks, on the corner of streets. Dr. Stillo and I, this is one of the first times we were there after, things started closing, elective surgeries started, coming to a stop. And, we're wearing, and most people that know me know that I don't like to be hot. And so wearing, an N95, wearing a shield, wearing goggles, wearing, double mask. This was a very crazy time that we're not used to. And one of the things that just stands out a lot, this mask here that was such a hot commodity, and it was very, very hard to find. I remember, Dr. Rendez and I went in one day for surgery. I think it was a maxillectomy case or something, and they were literally checking these out. So we had to scan. They took your badge and would scan to know that you had one N95, and we would get it for that day, while we were in the OR, and, reusing things. And, but it was incredible. The Empire State Building was ringing, was red and white and kind of looked like an ambulance siren. We're all trying to figure out where we can, how we can get this hand sanitizer. I remember Jacqueline from Biomed, who did a lot of our virtual planning with us and our 3D printing down in the Biomed department. She actually had one of these in her purse, was leaving in the beginning of COVID. And she had bought it at Walgreens, and it was confiscated from her when she was leaving because the hospital security thought she may be taking this home with her. I remember watching videos of Dr. Sanjay Gupta talking about how we need to wipe down all of our food. And, I was doing this. We all were doing this. We started now, I'm a hugger. You can ask Helen how much I love hugs. And now, we're going with the elbow bumps. It was just a really, really strange time. We had, New York just started changing, for some city that's so vibrant. It was like a ghost town. It was very eerie. And the only kind of movement we saw was going in and out of the hospital. And even then we were all so far away from each other, and, social distancing. But, there was a brighter day. And, at the end of our fellowship, with all the blood, sweat, and tears that we all put up with, we ended up having an amazing year. And so that I don't know, I really wanted to kind of reflect on that, because I just feel it was such an intense time for everyone, and going through a fellowship at the time of this, it changed everything. And the incidents that happened prior to that with the flood, with the listeria outbreak, all of that is just, it made for a very impactful year for all of us. So now I guess what I'm supposed to start talking about was, what am I doing now? And so I landed here in Boston, and I'm not the type of person that ever has a straight path to anything. And so my path has has always just gone this way. So why would it change when I came here? But my home base here is at Mass Eye and Ear Infirmary. And so Boston is a beautiful city. It's taken a little bit of time to get used to the snow and the weather, but the building here, the tan building here on our right is Mass Eye and Ear, and it's the head and neck division of Mass General Hospital. And so to even complicate it further, this is, a couple of months after I got here, Mass General and Mass Eye and Ear and Brigham and Women's Hospital merged. And so now all my credentialing, everything had to be done again because now it was under the umbrella of Mass General Brigham. So to kind of take things even further, these are the two campuses that I work on or work at primarily. The Mass Eye and Ear is up, in the northern end here, as well as with Mass General. The Shriners Hospital, which is adjacent to Mass General. I'm also a part of the craniofacial team there. But down on the Longwood campus, which is closer down to the dental school, like southeast of Mass Eye and Ear, is Brigham and Women's Hospital, as well as the Dana-Farber Cancer Institute, and also Harvard. So I'm affiliated. Well, my home base is at Mass Eye and Ear, but I do operate at Mass General and the Brigham. I also see patients at Dana-Farber, and I'm part of the faculty at the dental school in the oral surgery department. And at the Shriners Hospital, it's a fully stocked hospital. We are able to operate there, but usually it's during the craniofacial service, we go and see patients together. And then, once a month, and then we follow up with them in our separate clinics. So a lot of times the patients will come over and see us here. So this is kind of my crazy complex practice here. But my take-home message, I guess, with this, I was trying to think of some pearls that I've learned, particularly a lot of the things I've observed and learned and have adopted after my experience at MSK is, you need to develop your future and your vision. And the late Steve Jobs says, if you're working on something exciting that you're really passionate about, you don't have to be pushed. It just basically pulls you into that. And that's kind of how I feel here. Like I said, my path into maxillofacial prosthetics has not been linear at all. But I remember a couple months after being there, I was thinking, I was like, wow, this is what I was supposed to be doing all this time. And which actually turns out it needed to be, because that was the last step that I could go. You got to figure out your brand. I mean, I work in an institution in a hospital, but some people go out into private practice. And I remember this was told to me when I was in private practice, what is your brand? What type of practitioner physician are you going to be in establishing that? Relationships is very important, whether it's with our colleagues, patients, auxiliary staff, whether it's John is making your smoothies down in the cafeteria, or facilities. It's all very important to establish those relationships and to nurture those, and your mentors and mentees. So I've always been a mentee. Since I came here, I've actually been a mentor, which is really weird. But those are all important, to nurture as well, and with your fellows and your residents and all of that. One thing that COVID and the pandemic has taught me is work-life balance. I'm not an expert by any means, and I'm not at all balanced, but this is something that I've found that I'm really striving to work towards, because we've all had to take a pause. We've all had to kind of sit back and at some points we're forced to be still. So one thing I've learned through the pandemic is that how valuable and necessary that it can be for a work-life balance. And then professionalism. This is my shout out to my battle buddy, Dr. Randazzo. But I cannot stress this enough. I know this is, kind of I'm kind of laughing about this, but at the same time, MSK, I don't think you realize until after you leave how special it is and the level of professionalism that you experience there. From the time that you walk into the door, whenever you're even doing, I noticed that when I was doing my pre-op, not pre-op, but my pre-employment examination, and it is, MSK is so first class in my opinion, that it is something that I learned in developing these relationships. I really mean all of this. That is something that I've taken with me even here, and I've tried to implement, because I just feel like MSK stands alone, and is kind of the leader of what that means, whether it's within the community or within colleagues or within the patients. It is something that is so special, and you don't see it a lot other places. And I've been around a little bit. So, another thing is leadership, whether, whether or not you think that you are, you will become a leader, especially, in the military state, you're subject matter expert. So, when it comes to maxillofacial prosthetics, as well as dental oncology, oral oncology, we have the best training in the world, literally. And so when you go out into the community or out into another institution, people look to you to lead, and you're kind of put into this position whether or not you want to or not. But the other thing too is promotion. So for me, as a faculty member, we're always looking forward and getting involved in anything that you can. Try not to spread yourself out too thin, but promotion, especially here within the Harvard system, you've always got to be, they give you all the resources in the world, but you really want to take advantage of those, because it's very important for our profession as well, that we're continuing to learn and educate others. So these are kind of my take-home messages. Lessons learned. So one of the things, I learned after being here is that MSK, with its brand, with its name, it could definitely help you in so many ways. Everyone knows that. Patients know it. Other colleagues know it. It is really one of the greatest cancer centers in the world. But sometimes there's a lot of haterade out there, you can see. There are people that are always testing and challenging what the MSK way is. I've heard it a lot, especially with proton therapy, and Dr. Nancy Lee. So, the thing, even though you are challenged and even though people are testing you, I feel like that, after our training there, we are very well prepared to provide supportive evidence, that shows why we are, because you get used to that's being able to contour your patients, and you get used to discussing why you would not want to extract and place an implant in an area with a salivary gland tumor or floor of the mouth has received 70 gray radiation. I mean, these are things that we just know and we see every day. We're used to seeing ONJ, Mirage, ORN, and these are things that we see. So whenever I came here, I'm thinking like, oh, okay, this is what everyone knows. But this was one of the biggest learning lessons for me is, so I remember speaking with Dr. Stillo, and she actually told me this, find your tribe, find those that have the same philosophy as you, and kind of build your team around that, because as you come in, wherever it is, they're going to say, oh, it's kind of like in the military. Whenever people say they went to West Point, you're like, oh, West Point. So let's kind of test them to see what they know. And it's the same thing. MSK kind of has that. I mean, they are kind of the standard. So when you go out, you need to build your team, find your tribe, and have, find others that are kind of buying into what your vision is and your same philosophy is how you've been trained, and then kind of build upon that. One thing as well, I can't stress enough is just the way that you don't appreciate as a fellow, or at least I didn't. It's kind of annoying with all these emails, and of the whole team responding, but you really don't realize how important that is until after you leave and it's not there. And you're searching for other bits of information that we have just readily available to us there. So that this is something that I have I've brought with me here. I'm trying to be I guess a lead or an example, and trying to set the tone. And sometimes it is welcome, sometimes it's not, but I really valued that. If a patient was in another service, we found out about it, we knew about it, and we were able to help all together. It was a very collaborative way to treat patients. But don't be afraid to be the new guy. A lot of times, I have a lot of questions, and it's the only way, you'll figure out things if you ask questions. So don't be afraid to be that person. And I've learned, work-life balance is very important, and respecting others, the other team members that you work with, whether it's your in-office team or your colleagues, but also respecting their time is very important. So also during our fellowship, we lost Annette, which was tragic. And this is another reason why I was wanting to kind of do the recap in the beginning, because I started going through some of these photos, and we lost Annette, and I was actually off for my board exam in Chicago, and we never really had a chance because of COVID. Because around this same time, we were never able to really have a chance to kind of have a proper memorial. And so, there was just so many things that happened to us, or that we endured in addition to COVID. And this was one of the things that I wanted to kind of mention as well. I thank everyone for their time. I hope I didn't go over too much. I talk a lot. This is my contact information. We are accepting new patients. I've actually sent a couple patients to Memorial, but please email me or call me. If you have a patient that is in this area we can work with, or whatever, however I can help, I'm very happy to help. I'm here. And again, I wanted to thank everyone for your attention.
Thank you, Lydia. Fantastic job. I forgot to remind everyone, we will hold questions till the end. Please note your questions in the chat function, and we'll try to address them after Dr. Lee. So again, we welcome back Dr. Ryan Lee, class of 12, dental oncology. Ryan, good to see you.
Wow, what a fantastic presentation, Dr. Legg. I learned so much from that. Let me screen share. I know I have 15 minutes, give or take, so I'll keep my comments brief. Okay. Yeah, thank you, Dr. Sehi Yam, for asking me to present a couple of slides on basically how MSKCC has been such an integral and phenomenal part of my training. It still shapes me today, about 10 years later. And so I just wanted to share a couple of slides, my journey in brief since Memorial Sloan Kettering. My name is Ryan Lee. I'm currently the chief of the dental medicine department at a place called Cambridge Health Alliance, which is also right in your neck of the woods, Dr. Lydia Legg. So we will have to talk, and I'm gonna have to send you a lot of the cancer patient cases to you.
Yeah, I'm sorry, I didn't know. Thank you.
Yeah, well, I'm right here. So let me keep going. I have no disclosures, conflicts of interest with any of the stuff that's on this presentation. Cambridge Health Alliance is a health system in the northern suburbs of Boston. So Cambridge, Somerville, Everett, about 8 to 10 towns, 3 hospitals, and about 20 health centers. And there is a Department of Dental Medicine that I am currently helping to lead as the chief. There is a GPR program with 4 first-year residents and 2 chief residents, and we have a nice program. The mission is public health, social justice minded. But at the same time, we do quite a lot of implant cases. We have dedicated OR time every week. So we try to do the best we can to educate our patients, educate our residents, and provide care regardless of somebody's ability to pay, whether you're rich or poor, Black, white, Asian, Hispanic, whether you're documented or not, abled or disabled. We try to do our best to provide what we think is top of the line service in a setting that is affiliated with Harvard and with a nice residency program to boot. This is what I did since this is my background. I went to NYU for dental school. Prior to that, I went to Northwestern for undergrad, did a couple other things. And then I went to Jersey City Medical Center for a GPR. And at that point, I remember there was a cancer patient and the OMFS attending said, Ryan, don't touch that patient. Don't touch that patient. Send the patient to UMDNJ. Don't touch that patient. So I said, what the hell? Why not? You know, it's our job to provide good care for, you know, a guy with cancer. Knew nothing about it. And then one thing led to another, applied to Memorial Sloan Kettering's Dental Oncology Fellowship, had a great time, learned so much. And since then, got a part-time teaching job at NYU. They didn't have a dental oncology program, right? So they said, why don't you run the special needs clinic? So I said, okay, no problem. Rented a chair in Midtown Manhattan for like $300 a day and started building up a small private practice dental oncology, you know, practice based on referrals from area hospitals. I was always part of the Army National Guard. They helped pay my loans off. And then, you know, when I needed more money to pay for my wedding and buy a wedding ring for my wife, it, you know, kind of became a traveling implant guy for a bunch of practices at 1.5 different practices in like 60, 70 mile radius. But eventually got married. Wife's a dentist. She teaches at Tufts. She's an orofacial pain person at MGH and Tufts. And then she said, you know, I'm the wife, so you better move up here. Happy wife, happy life. So I quit the NYU thing, got married. That's her and me. It was like 2014 already. Feels like 100 years ago. You know, had a great time. Had a kid. She was good. I liked her. Had another kid. I liked her too. And then had another, you know, the two of them got along a little bit, you know, and then I said, you know what, let's do one more. So we got another one. So now a family of 5. And I literally, my nickname is trash receptacle, like garbage can at home, because whatever food is left over, I eat. So that is my contribution to my family. But you know what I did is I moved up to Boston, and then I had a hard time getting involved with an academic center with the oncology fellowship. So I said, you know what, maybe the leaves are turning in a different way. Maybe I'll go into private practice. So I joined the DSO and I started doing some oncology there. Did a lot of implants for cancer survivors and patients, working with other specialists. And then I opened a practice in Brookline, another one in Plainville, and then another one in Rhode Island, general practice. And then got one in Connecticut, and then opened another one in Harlem. So I have 5 now. And so life's been a little crazy with the Great Resignation since the pandemic. But my true passion has always been dental oncology, really, thanks to Dr. Huryn, Dr. Astillo. I mean, I remember Dr. Boley was there before, the 2 oral surgeons, Dr. Tunick, Dr. Halpern, phenomenal folks I learned from. I'm sure they thought I was a pain in the ass, but I mean, I learned so much. It changed my life. Even to this day, I mentioned Memorial Sloan Kettering. I talk about the brief time I spent there, and the conversation changes. These people think, oh my God, you must be an expert. And I say, no, I'm just a general dentist who's comfortable with dental oncology and managing some complex medical folks, but get all these referrals, even now, Boston, New York. I still go down there a couple days a month, got a couple of associates working in Midtown. So still do it, love it. It's just a sampling of obviously hospitals that sometimes refer patients to us. Obviously, you got to do extra work, talk to the radiation folks and talk to the other oncologists and say, hey, dentistry isn't just fixing teeth or pulling teeth. You got to do all this, right? So write letters. There's the website. I remember one time there was the nation's first penile transplant guy. I didn't know it was him until later, but I took out his teeth to get him ready for surgery. And then only later did I realize, man, I know that guy. And then I realized I was probably one of the first dentists to do oral surgery, dental clearance for the nation's first cancer survivor that needed a penis transplant. So that's a story I like to tell. So these are some other websites, private practices. But, you know, I take pride in dental oncology and clearance, you know, pre-RT, pre-chemo, pre-whatever. That's not just taking out a couple teeth and, you know, talking about fluoride, right? These days, I try to actually place implants. I try to even load. I try to even do immediate placement and load, bone grafting. everything prior to folks starting IMRT or radiation therapy, right? Because I believe so strongly that quality of life and the ability to function, eat, smile, go on interviews, have a romantic life is so important as a cancer survivor that, to me, implant placement is a consideration and conversation in every dental oncology visit. So, thanks to all the technology by the smart folks, now we can do guided surgery. What used to take me like 6 to 8 hours in the OR, it can now be done in like 2 hours outpatient with just IV sedation, right? So it's so cool that we can do this. And now we teach our residents to do this. And so, dentistry has been amazing. I've had some opportunities to travel, go to like places like in Africa and Central America, and, this is Paraguay, and working with some implant folks. And obviously during the pandemic, dentistry is such a respected profession that if you just raise your hand and say, hey, listen, I can help out in the front lines, they'll come asking for you. So Charlie Baker, who's the governor of Massachusetts, said, hey, all the physicians and nurse assets got pulled into the Holyoke Soldiers Home because there's been a debacle with a lot of folks dying. Dental officers, can you step up and do something? So we said, okay, no problem. So we traveled to we trained a lot of soldiers. We traveled to probably about 500 nursing homes all across the state. I mean, all the offices were closed down for like 4 months anyway. Went to psych wards, hospitals, homeless shelters, and I led a bunch of mobile strike teams. We did something like 40,000 nasopharyngeal swabs. And then later on, we became vaccinators too. So this is downtown Boston, doing this kind of stuff in hazmat suits, back then, right? And so got some coverage on this. And then I said, you know what? I'm in my early 40s now. The private practice thing is kind of burning me out. Is it okay for me to have a midlife crisis? I asked my wife and she said, if you have a midlife crisis, then do something about it. So I did something. So I said, okay, let me go back to academia. So that's why I joined Cambridge Health Alliance. So let me talk about that a little bit. Right now, we're in the middle of an expansion. We're going from a 7-chair dental service to 23. So it's not a big number in terms of dollars, but it is the first time in the history of Cambridge Health Alliance ever that we're doing an expansion of dental services. We want to be a national model of excellence when it comes to dental medical integration. We want to grow not just in one direction, but multi-directionally. So yeah, we're doing a lot of this cool stuff. I remember this is my first implant, like in 2008, 2009. It took me like 3 hours. This is during my dental school. I literally, no joke, I had to go feed the parking meter of this guy because in the middle of it, he said, hey, I'm gonna get a ticket. And I said, no problem. I took my gown off, went downstairs. NYU is like 11 floors, right? Fed the meter and came back. I'm not even kidding. Nowadays, with all the technology we have, unbelievable with all the interprofessional collaboration we can have. You can do zygomatic cases guided. You can do all of these crazy cases, full mouth, full arch in just a few hours, safely, more predictably, right? So we're lucky to have all these tools at our disposal. And I remember the first time I even touched the CBCT and actually like touched the mouse was under Dr. Huryn's guidance. And so I still think about Dr. Huryn every once in a while when I plan a case on a CBCT. But our GPR residents do cases like this. And our GPR residents, we have 4 now, 6 next year. They do about 80 to 100 implant placements per year each. So it's a lot, right? And so we spend a lot of time really thinking about bringing implant care to folks that otherwise couldn't afford it in private practice, right? So yeah, oral health integration with the rest of medicine is one of my passions. And that's one of the things that we're doing, talking to different departments in the hospital. And cancer and oncology is such a big part of this every time. I talk to a lot of non-dental providers like MDs and nurses, thinking about what the heck is dental insurance versus medical insurance? Why is dentistry so expensive? Blah, blah, blah. What can MDs learn from us? Because we have so much expertise, right? Maxillofacial prosthetics is just that field alone. I don't even think most physicians know. I mean, there's so much expertise. You can change a person's entire life, right? And so, work together with ENT. That's just an example slide. Come up with sort of workflows and sort of logical diagrams that didn't even exist in the hospital setting, right? They thought that dentistry was just do whatever mass Medicaid covered, but now we're trying to change that, right? So, yeah, a couple more pictures of the journey that dentistry and the training that I got at places like Sloan Kettering have offered. Unbelievable stuff. An earthquake after Haiti, just a blessing to be able to go there. North Korea, which is a closed country. One day they said, just go to a bread factory and make bread instead of doing dentistry. I said, no problem. More preventive care. It's not just pulling teeth. We want to educate folks, work together with the dentists and doctors that are in the local population who are so much better than me. They already speak the language. This is a dean of a dental school in Port-au-Prince, Haiti, a good friend of mine. We've even had Haitian dental students and young dentists come to visit my office in New York City. So I sponsored a visa in some way, and then they got to see some implants being done, visit the Greater New York meeting, talk about business, go visit some other places. It's talk to nurses in the middle of a jungle about, dental oncology. It's crazy. It's amazing, right? Stuff we can do. So I just wanted to say thank you, Dr. Sehi Yum, for inviting me to share a couple of comments. I don't think anything I'm doing now could have been possible without just the wonderful expert training I received at Memorial Sloan Kettering, to be honest, but also just the general sense of confidence that, hey, I'm a dentist. I take pride as a dentist, but at the same time, man, I have a level of confidence that I got to see something and work with a patient population that's incredibly rare and difficult to work with. And that has led to some amazing opportunities and opened up some lot of doors. Not gonna lie, sometimes no one, sometimes people don't just say, oh, wow, dental oncology, here you go. Why don't you become a division chair right away? They're not going to do that for you. But if you are willing to market yourself, I'm talking to some of the current fellows now, and get a teaching job, perhaps combine private practice or not, but you can do so many things in the areas of clinical care, academia, even military leadership. You can do politics, you can do advocacy, you can do so much. And so I just think MSKCC has been a life changer for me. And I'm just glad that I can share a couple of slides and at least say thank you to the attendings that changed my life back in 2012. That's it. That's my email if you want to contact me in some way. And thanks for this opportunity.
Well, thank you both. I mean, two excellent presentations. Are there any questions, or shall we wait till the end of the fellows' presentations? Dr. Yam.
Yeah, thank you so much to the both of you. When we reached out to the both of you, we didn't realize there's so many things in common: military, Boston area. So it's kind of nice that there are some commonalities here. I just want to thank you both so much. Ryan, I haven't seen in a million years. Great to see you. We're on par 3-on-3 with 3 kids, but we have some time right now for question and answer. If anybody has a question, you can write it in the chat, or if there aren't that many, then you could also unmute and ask a question. We have about 7 minutes or so.
All right, so let me start. I mean, this is something I tell fellows, the graduating fellows, all the time, and you two have personally taken it to heart. Starting off with that first academic appointment, or even before that, joining a tumor board, even though you're not part of the faculty, getting your name out there. I mean, how important has that been to both of you?
Well, for me, I'll speak for myself. If you say MSK, and people say Memorial Sloan here, they don't say MSK, or they don't say Memorial or Sloan Kettering, it's Memorial Sloan. I mean, it is like Ryan was saying, it's as if you are walking, it's like laid, I mean, the name precedes us. The level of excellence precedes me, and it's like an automatic check for credibility. And it's like, oh my gosh, I'm sure if they only knew the real me, they would probably not think that. But I mean, it really has opened so many doors, and I'm just happy to be a part of it, because it's not anything that I have done, but the MSK name has, people know what they're getting when you've trained there. And so, I've had a couple people test me though about Nancy Lee and the proton therapy, and, just kind of our philosophy there. But yeah, I mean, for me, it's opened so many doors, and I feel like it's more on me to have to live up to that name and being associated with it, as opposed to the other. So
Yeah, and I think it's, as Ryan said, I mean, it's also marketing that, because how would they know you were at Memorial? So I think for our fellows, our future fellows, our current fellows, I think that's an important first step in marketing your skills, telling them, and you hear me say this all the time, we're not just a drill and fill operation. There's so much more to dental oncology and maxillofacial prosthetics than the general dentist will know about.
And Dr. Huryn, one of the things I did too when I got here, because small fish in a huge like ocean, I just put together like a basic introduction of what is maxillofacial prosthetics in dental oncology, and because even some of our colleagues, within head and neck or plastics or whatnot, they still thought that we are only making an obturator. So
Right.
That was a good way just to kind of introduce myself and lecturing, speaking to other services.
Any comments, Ryan?
Yeah, I echo Dr. Legg's comments. I think it's humbling for me because mentioning Memorial MSKCC gives me an incredible level of credibility that I don't even think I sometimes deserve. But, I'm going to just do my best to really put in the extra work to do the best I can for the patient in front of me. And 99% of the time I realize, as somebody who went through this training, I know so much more and I've seen so much that I am able to contribute in a positive way. There's no need for me to shy away from that. And Dr. Huryn, your point, it is important to market yourself and to say and describe, hey, this is dental oncology. This is what a dentist can do for cancer patients pre, peri, post, right? I mean, you can change somebody's life. And so I think doors start opening up. Dr. Huryn, do you want me to answer Dr. Tewolde's question on the chat?
No, let's hear it because
Yes.
we'd like
Yes.
to hear what the question is and
Yes.
your response, of course.
Yes, that would be great. Are you able to see the chat? Okay.
Yes,
Great.
the question is, what motivated you to join the GPR in Cambridge and what aspects of leading a GPR do you find most rewarding? I just full disclosure, I don't run the GPR program. There is a GPR director that does report to me, but I work closely with him. But when I do work with the residents, I honestly, I think that there is mentorship that I can provide clinically, but also just about life, about the challenges of the dental profession these days. So it's probably one of the most rewarding things I do. I talk to my wife, when I come home about residents and what they're doing. Many of them want to combine private practice with academia. Love the GPR program, and I hope I can work with GPR residents or some trainees at all times for the rest of my life. That would make me happy.
So one question I had was this idea of dental insurance versus medical insurance. And it seems like you're making some headway in trying to kind of unify the insurance types or make it more inclusive somehow. I think it's like a valiant effort because that's a conversation that we have all the time. Like, why is this not being covered? Because in the dental oncology setting, they feel that all the dental treatment should be covered under their medical insurance, and it's not. And it's a struggle sometimes because you wish also for the patient that all of dentistry can be covered while they're undergoing like oncologic care, or there are some impact. It seems like, you're making some headway there. What steps are you taking, or, what are your thoughts, about how something like that can be done, if it's possible at all?
Dr. Yum, is that for me?
Oh yeah, sorry. Sorry,
Yeah,
Doctor.
I'm going to be honest and say I am not an expert in any way when it comes to medical dental insurance billing. I try every week. But kindly, politely yell at the billing department at our hospital to say, hey, this is directly connected to the systemic health and the medical complexity. So this is not just an implant. This is not just an extraction bone graft. And so I think we just send out the CPT and the ICD-10 codes, and I provide whatever narrative I'm supposed to. But we all know how difficult it is, right?
Yeah.
Especially in the private practice setting. I write narrative after narrative, letter after letter, and it's like 10% success rate. that medical insurance sometimes covers it. But in the last 3 to 5 years, I found that even as a solo practitioner, you can get medical insurance reimbursement for things like oral surgery, things like sleep apnea appliances, maybe not veneers, maybe not just simple fillings. So I think it is a growing field. And I'm not even making this up. I learned about it by talking to some of the folks at MSK. I remember Dr. Huryn and Dr. Silla, I guess the charge out reimbursement forms where you check off the different CPT, ICD-10 codes. That's the first time I saw it, So again, I owe that to my experience as a fellow at MSK, but I'm not an expert in that field.
Thank you. Thank you both for answering some of our questions and for your wonderful, wonderful presentations. Yeah, really excellent and really inspirational, actually. So thank you so much for that.
So Dr. Pennings, take it away.
All right. Great. So first off, I'd like to just thank Drs. Legg and Dr. Lee for such a great presentation from both of you. I really enjoyed both of those talks, so I appreciate your time today. I'll be sharing a shorter presentation about Fanconi anemia and the treatment of patients with Fanconi anemia at MSK. So a little bit about me. I'm originally from Idaho. I went to college in Minnesota, and then I was a high school biology teacher in Washington, D.C. for a few years before I went to dental school. I attended dental school at Creighton University, and then after dental school, went to Loyola University in Chicago to complete a general practice residency. And from there, I found myself at MSK for the Dental Oncology Fellowship. So here at MSK, we're very familiar with head and neck cancer. About 30,000 new patients present annually with head and neck cancer in the United States. And of these, most epithelial malignancies are squamous cell carcinoma. Risk factors include tobacco and alcohol use. 3 separate reports have shown a 500 to 700-fold increase in the incidence of head and neck squamous cell carcinoma in patients with Fanconi anemia. So what is Fanconi anemia? It's an inherited form of aplastic anemia. It's quite rare, so 1 in 650,000 patients or people will have Fanconi anemia. It is an autosomal recessive disorder characterized by a high degree of genomic instability. In particular, there is DNA cross-link damage that can predispose these patients to developing cancer. There are some physical manifestations, including short stature, skin hyperpigmentation, malformations of the heart, kidney, and even limbs. And then these patients also experience progressive bone marrow failure. Unfortunately, unless a bone marrow transplant is performed, the mean age of death for these patients is 15 years of age. So as you can see, this graph has on the x-axis time in years or age, and then on the y-axis is cumulative incidence. So for these patients, onset of Fanconi anemia occurs by the age of 10. The overall mortality for these patients by the age of 50 is near 100%. And then they are at an increased risk for hematologic malignancy, solid tumors, and then finally squamous cell carcinoma. So for these patients, cumulative risk for developing head and neck cancer is approximately 14% for patients surviving to the age of 40. In this table, you can compare that 14% to the non-Fanconi anemia head and neck squamous cell carcinoma cumulative incidence rate of 0.03%. So there is a significant difference between patients with Fanconi anemia. The median age of presentation of head and neck squamous cell carcinoma is 31 years for patients with Fanconi anemia. And interestingly, in most people with head and neck squamous cell carcinoma, they're heavy users of tobacco and alcohol. Only 16% of patients with Fanconi anemia use tobacco and alcohol. So it truly is because of their genetic predilection to developing squamous cell carcinoma. The primary tumor site is the oral cavity in patients with Fanconi anemia. So 65% of all squamous cell carcinoma will be seen in the oral cavity in comparison to the non-Fanconi anemia population, where most of the squamous cell carcinoma will be seen in the larynx. 63% of patients with Fanconi anemia will develop secondary primary tumors. And then the biological behavior of Fanconi anemia-associated head and neck squamous cell carcinoma is considered aggressive. There is early soft tissue and lymph node metastasis, which results in an overall poor outcome for these patients with only 49% 2-year overall survival. And furthermore, because Fanconi anemia is a myelodysplastic disorder, traditional treatment, including chemoradiation, has some significant side effects. And so surgery is the primary curative modality for these patients. So I'd like to present the first case, which we saw at MSK a few years ago. This is a 6-year-old female who was seen for a pre-BMT evaluation. So she came to us prior to transplant. And as you can see, that she is missing her thumbs bilaterally. She was also missing her right radius. She also had a horseshoe-shaped kidney and experienced a short stature and a defect in her atrial septum. So she had a classic presentation of Fanconi anemia. And then in her oral cavity, we saw these mucosal lesions on the maxillary and mandibular gingiva. Per her parents, they'd been there for about 5 to 6 months. And she had good oral hygiene. She was overall eating well, but she had these mucosal lesions. So with patients with Fanconi anemia, you do see gingival alterations and gingival bleeding. They could have increased inflammation of the gums and are thought to be more susceptible to periodontal disease. Additionally, these patients can have papillary atrophy of the tongue, macroglossia, and melanic pigmentation of the oral cavity. Also been reported, but not as frequently, are the presence of mesiodens, delayed tooth eruption, supernumerary, and missing teeth. And so you can see here, this patient actually has some delayed eruption occurring with only one of her permanent teeth shown in the photo. The next case is a 29-year-old female. So she came to us after having squamous cell carcinoma of the tongue in 2011. So she underwent a partial glossectomy and neck dissection with Dr. Singh. And so we saw her in our clinic, and she had some of these similar gingival alterations that we saw in the first patient. And as you can see here, for a 29-year-old female, she had a significant amount of bone loss. So she had periodontal disease. And then with her tongue, you can see some of the deep papillation and then also some of the macroglossia. And unfortunately for this patient, she developed a recurrence. She's part of the 63% that will develop a second primary, and she ultimately passed away from this disease. So, is there anything that we can do for these patients, given that they have such a high cumulative risk for developing squamous cell carcinoma? So typically, the general preventative measures that work for the general population are also recommended for patients with Fanconi anemia. So we can counsel them to abstain from using tobacco and alcohol. If they haven't got an HPV vaccination, it could be helpful in preventing HPV-associated oral cancer. And then also, it's important that they maintain proper oral hygiene. But most importantly, active surveillance is necessary for these patients beginning at 10 to 12 years with a focus on the oral cavity. So at age 10, they should have a head and neck exam by an ENT. And ideally, this could be a flexible fiber optic exam of the nasopharynx and oropharynx. If there's a normal exam, the patient could be evaluated semi-annually. However, if they are showing any mucosal changes, including lichen planus, leukoplakia, or erythroplakia, excisional biopsy is recommended. So because of these patients, a proclivity towards developing squamous cell carcinoma, it's very important that we're a bit more aggressive when taking biopsies for these patients. And if a biopsy is performed, increased surveillance timing should be, or we should increase the timing of the surveillance to every 2 to 3 months. And then obviously, if there's a lesion that's suspicious for squamous cell carcinoma, you want to do a biopsy and then make sure that they receive appropriate treatment. So how does this affect us as dentists? Familiarity with the condition is important, in particular, their increased risk for head and neck squamous cell carcinoma. So As dentists, we actually play a very significant role in the detection of malignancy for these patients, given that 65% of the squamous cell carcinoma that develops in Fanconi anemia patients is in the oral cavity. So optimal oral care and hygiene is important. Counseling against use of tobacco and alcohol is important. And we can also, help patients to take these preventative measures to reduce their overall risk of malignancy. So as a take-home message, reports show a 500 to 700-fold increase in the incidence of head and neck cancer in Fanconi anemia patients. So 14% of these patients will get head and neck squamous cell carcinoma before the age of 40. So aggressive active surveillance is required for these patients. So although this is a very rare condition, at MSK, we actually have been able to see and treat a lot of these patients and help them through different parts of their care. So I, like probably everyone else on this call, feels very privileged to be a part of MSK and be able to offer care to our patients in this setting. So again, I thank you all for your attention today and for your continued involvement with the program. And I'm happy to answer any questions that you have.
Thank you, Dr. Pennings, for your presentation.
Yeah, thanks.
All right, Dr. Tuwalda, please continue.
Okay. Good morning, everyone. My name is Kadani Tuwalda, and today I'll be presenting a case of a patient who developed draining extraoral fistula after completing quad shot radiotherapy. So a little bit about me. I grew up in a small town in upstate New York called Oneonta, and I went to SUNY Albany for college. I then went to NYU for dental school, and I moved up to Buffalo, New York to complete my 1-year GPR training at Erie County Medical Center. And this is where I was first introduced to treating patients in an oncologic setting. And now I'm here at MSK completing the Dental Oncology Fellowship Program. So Mrs. B, our patient Mrs. B is a 66-year-old female originally diagnosed with squamous cell carcinoma of the right buccal mucosa in September 2020. She was initially offered surgical treatment with curative intent. However, she declined due to her fears of being alone and isolated during her admission stay. She then started cycles of carboplatin, paclitaxel, and cetuximab, and she also completed radiation therapy of 4 cycles of quad shot while on concurrent nivolumab treatments. And through chemo and radiation, she had a great response, as seen with her PET scan in September 2021, 1 year later, and showed no evidence of disease in the oral cavity or the floor and mouth, and no disease systemically as well. So due to the state of her disease condition, her radiation oncologist determined that definitive radiation treatment was contraindicated due to the high level of toxicity. So with curative intent with radiation not a viable option, palliative care became the frame of context for treatment. And with palliative care in mind, the quad shot radiotherapy is actually the best combination of treatment efficacy, toxicity, and patient convenience. The goal of quad shot radiotherapy is to control the patient's symptoms, improve their quality of life, and prolong survival. The integral factor for the success of quad shot therapy is in its hypofractionation technique. This is a radiotherapy regimen where radiation is administered in fewer but larger doses or fractions at a time. So with Mrs. B's case, she was treated with photon-based energy. So for a single quad shot cycle, she was treated with 14.8 grays of radiation, which is broken down into 4 fractions over 2 days at a time. So for the first day, she treated with 2 fractions, and then the second day, 2 more fractions. And in this 2-day time period, that's 1 cycle of quad shot. And the cycle is then repeated for a maximum of 4 times, about 3 to 4 weeks apart. So she started her first quad shot treatment in March and ended in June of 2021. So when it comes to palliative care, the quad shots is an extremely effective form of treatment, especially when it comes to patients who have been previously irradiated for head and neck cancers and have recurrences in their disease. And due to their previous treatment of radiation, they can't undergo further definitive treatment with radiation, and sometimes the recurrences are not amenable to a surgical option. So quad shot therapy is a viable last line treatment to control the patient's symptoms. Here at MSK, the radiation department published a study in 2020 looking retrospectively at a group of patients who were diagnosed with recurrences in their head and neck cancers and and who were previously treated with radiation and couldn't undergo further definitive radiation treatments. So out of 166 patients, 92 patients were treated with photon-based energy and quad shot, and 74 patients were treated with proton-based energy quad shot. And all these patients completed 4 cycles of quad shot therapy. And studies tracked the tumor reduction over time. And effectively, the study showed that 60% of the patients had reduction of the symptoms of pain, dysphagia, trismus, and bleeding. And moreover, the study also tracked a 6.4 median overall survival rate, with 25% of the patients actually having a 1-year survival rate. And the study also tracked the local regional decrease of disease in these patients who were treated with quad shot therapy. So here, these are the MR images of a 65-year-old male diagnosed with a recurrent oral squamous cell carcinoma. So in panel A, the right arrow is depicting the large area of depicting the the tumor where in the oral cavity, and we can see its large size as we move from left to right. And in panel B, we can see the decrease of the tumor after the patient underwent quad shot therapy. So all in all, the authors of the study are trying to show how in this patient pool of patients who have such restrictive options for treatment, quad shot radiotherapy as an effective last line option for treatment. So this is our patient when we first saw Mrs. B in November of 2021. You can see the large radiolucency in the right body of the mandible with its mothing and borders extending from tooth number 29 to tooth number 31. Here, this is the area where the tumor is essentially infiltrating into the body of the mandible. The mandibular molar is extremely mobile, and this is before she started any chemo or radiation treatment. And here in April, we see the patient after 2 cycles of quad shot therapy. So we can already start seeing the fracture of the right body of the mandible and the collapse of the mandibular molars into the radiolucent space where the tumor was infiltrating. We can also appreciate the displacement of the right condyle as well. So as the radiation is effectively treating the tumor, treating the cancer, and the cancer cells die, the mandibular body is essentially contracting into the space that's left. Then roughly a few months later, in February, the patient exfoliated tooth number 30, and now tooth number 31 and 32 are sharing the same fate as they collapse mesially into the leftover space where the tumor was infiltrating. Still, the patient maintains this palpable step fracture, and the patient, since beginning quad shot therapy, has anterior and posterior open bite and malocclusion, along with the other sequelae of radiation treatment. So here in this image, taken in December, we can appreciate the 2-centimeter extraoral draining fistula. She first presented to the dental service with it back in October 2021. The fistula is draining pus, the remaining saliva that she can produce, and also any other oral liquids that she consumed. This is about the maximum amount of opening she can achieve. From the minimal intraoral exam, we can appreciate exposed necrotic bone along the right body of the mandible, and also we can start seeing the nicotine stains, the tobacco stains from her long history of smoking pack a cigarette for about 35 years, along with recent chlorhexidine stains of her teeth. So from these images, we can also appreciate the lymphedema of her lips and also the right side of the cheek. As time went on, the patient continued with her lymphedema treatments. The lymphedema physical therapy greatly improved the patient's erythema along the right side of the cheek and also the edema of her upper and lower lip. However, still the skin around the extraoral fistula is still fibrotic and tough, all due to the sequelae of the quad shot radiation treatments. She still maintains a puree diet. She can't eat any hard foods and the only way she can really upkeep with oral hygiene is by simple rinsing. So currently, Mrs. B reported back to the surgery department for consultation in January, where she was recommended mandibulectomy and fibular free flap reconstruction. Still, she remains with no evidence of disease, as seen in her PET scan in January as well. She's been on a low-dose augmentin prescription for several weeks to try and curb any acute exacerbations of infection. So for a few months, starting from October until February, the patient was deferring surgical treatment due to her fears of being isolated. However, recently in early March, the patient reached back to the surgery department to begin the process for fibular free flap reconstruction and eventual closure of the soft tissue for the fistula, and hope to be part of her case as time moves on and to be able to provide some support in any capacity I can. So thank you so much for your time. Thank you for your presentations, Dr. Lee and Dr. Legg. I also want to say thank you to my mentors, Dr. Kolbeck and Dr. Millord, who are here today. Appreciate your time.
Okay, so we'll continue with Dr. Harrison Spatz.
Actually, Dr. Huryn, Dr. Spatz is in the OR with Dr. Randazzo, so I'm going to go.
Okay, well, that's, you know, that's part of the MSK.
First surprise of the meeting. Good afternoon, everybody. My name is Anthony Farmer. I'm one of the maxillofacial prosthetic fellows this year. I just wanted to start off by telling you guys a little bit about myself. I was born in Syracuse, New York. And then when I was very young, my family moved down to Florida, the Orlando area, a little town outside of Orlando called Mount Dora, Florida. And then I went to the University of Florida for my dental education, graduated in 2018. And then also my prosthodontic residency at the University of Florida and graduated in 2021. So the reason why I wanted to do the maxillofacial prosthetic fellowship is because, number one, I wanted to learn more about, I thought I needed to have more education in dental and oral oncology and just oncology in general. I wanted to learn more about how to treatment plan these difficult cases. And then I also wanted to learn how to fabricate these the different prostheses that we know about, maxillofacial prosthetics, the obturators, the extraoral prostheses, and the different prostheses that we use for augmentation purposes. The last reason was I wanted to help this gentleman out here. This is my grandfather who wears an obturator, and this is the rest of most of my family. This is me and my wife here. We've been married for about a year now. This is us at one of the observation decks in New York City. You can see the Chrysler building in the background here, and these are what my wife likes to call our fur babies. This is Proton on the left. She's 9, and Pablo is 7 or 8. I wanted to tell you a little bit about my research topic. A lot of the alumni know about this prosthesis, the cyst decompression prosthesis that we've been using here at MSK for some time now. So a lot of you know that treatment that we do here for these types of patients is, number one, the oral surgeon diagnoses the cyst. The cyst is marsupialized or exposed to the oral cavity, basically, and then we use the decompression prosthesis to basically relieve the pressure created by the cyst and help reduce the size of the cyst and bone to fill in the area. The objective of the research is to present a case documenting the reduction of a dentigerous cyst using the acrylic prosthesis. So you can see here the prosthesis, it's retained with clasps, and then we fabricated an acrylic extension to go down into this cyst cavity to reduce the size of the cyst. And you can see here the cyst on the day of delivery for this particular patient. The case that we're going to present to the literature, hopefully, was this case here. The gentleman presented to Dr. Tunick's private office in November of 2020. And you can see here the size of the cyst almost looks multilocular, but I think it's a unilocular cyst. And then not long after this date, Dr. Tunick did a biopsy and it was confirmed lentigerous cyst. And then in June of 2021, he marsupialized the cyst, and then we delivered the cyst decompression prosthesis the same day. And then you can see here in September of 2021, a 3-month follow-up, you can appreciate already the impressive reduction in size of the cyst and the bone fill in this area. And then here in October, a 4-month follow-up, this is a panoramic image taken from the CBCT. And again, you can appreciate the reduction in the size of the cyst after only 4 months. And at this time, the patient was instructed he could remove the prosthesis. The last thing I want to leave you with is an interesting case of Pinborg tumor or calcifying epithelio-odontogenic tumor. It's a very rare case, as you know. I wanted to present this. We thought about using the decompression prosthesis for this case, but we actually decided against it, and I'll show you why here in a second. So just a little bit about some background on Pinborg's tumor. Most commonly, it's seen in middle-aged patients. There is no male or female predilection. The most common signs and symptoms that the patient shows, the patient reports is a painless, slow-growing mass, and 2/3 of these entities are shown in the mandible. Some radiographic characteristics, it can be either unilocular or multilocular. It's known for showing these kind of radio-opaque flecks here, or sometimes very strong, large calcifications that can be referred to as driven snow. 50% of the cases you will see they'll be associated with an unerupted tooth or a dental hamartoma, which, as we know, is sort of normal dental tissue, but it's just growing in an abnormal way. Histologically, the tumor can present with these sort of polyhedral sheets of epithelial cells, and then these basophilic rings that are inside these amyloid-like structures or plaques that are referred to as leaf gang rings. So this is our patient here. She's from Florida, 30 years old. The mass was discovered kind of like usual. It was an accidental finding on a panoramic radiograph during the dental cleaning. The dentist then referred her to the University of Miami, where there was a biopsy done confirming CEOT. The University of Miami recommended segmental mandibulectomy with a fibula free flap reconstruction. The patient also wanted a second opinion, so she went to U.S. Health in Jacksonville, where they recommended the same treatment. So she came to MSK for a third opinion. She presented to us with some kind of mild asymmetry and edema on the left side here, which you can kind of see. She did have some tenderness to palpation in the lower left cheek area as well. She had some mild discomfort in the TMJ area that she reported radiates to the ear from time to time. And then she also reported some transient paresthesia in the lower cheek, left cheek. You can kind of appreciate here some of the buccal expansion, which you can appreciate a little bit more from the occlusal view. And then from the initial visit, the panoramic radiograph, you can really appreciate the tumor here in the lower left mandible. You can appreciate the large calcification here associated with tooth number 18. And you can see here, this is why we did not want to use the decompression prosthesis in this case, because we were worried about jaw fracture possibly. And then we also didn't want to put any pressure on any graft that was going to be done at the time of the surgery. So this is the day of surgery. Dr. Halpern and Dr. Cracciolo took the patient to the OR. I was the one just documenting the case. So you can see here, this is after Dr. Halpern unroofs the cyst, and you can see here the calcifications. You can appreciate a little bit more of the buccal expansion here. This is after the sample was removed. You can appreciate the many calcifications here, and then the unerupted tooth number 18. And then this is after the cyst was removed. You can appreciate just the sheer size of the cyst, again, the buccal expansion. So very impressive, size of the cyst here. This is a 1-day post-op panoramic image that was taken. So you can appreciate here the tooth that was removed. Unfortunately, the The anterior alveolar nerve was running right through the bifurcation of the molar here. So when Dr. Halpin removed the tooth, unfortunately, the nerve was damaged a little bit. The plastics team and Dr. Shazad was called in and did a graft of the nerve, and then Dr. Halpern laid a resorbable collagen membrane over the nerve, and then placed an allogeneic bone graft, and then another resorbable collagen membrane over the graft, which you're seeing here, and then close the area. And then finally, you can see a 2 months post-op, the really, very impressive healing that has taken place. Unfortunately, the patient, though, is experiencing some neurogenic pain, which she's being monitored for at this time. But, what a great service that, Dr. Halpern and Dr. Cracciolo did for this patient. She was facing, like I said, a segmental mandibulectomy with fibula free flap reconstruction, which, a lot of times don't have any complications or have less complications, but sometimes they can, suffer some severe complications from that surgery. And her being only 30 years old, what a great service they did for her. So lastly, I just wanted to say thank you to all the faculty and administration for giving me the opportunity. I want to thank the staff for all the help here. And then I also wanted to thank all the alumni, the ones who who you are, who helped me in the transition from my residency into the fellowship here at MSK. So thank you very much.
Okay, so we'll open the floor to questions for our fellows, if there are any.
I could present because I'm
Oh,
back.
you're back. Great. All right. Just
Yeah.
in time.
Yeah.
Dr. Harrison Spatz, take it away.
Yeah, sorry, we had two surgical operators, Dr. Rendazzo and myself, so we just finished. Good afternoon, everyone. My name is Harrison Spatz. I'm one of the maxillofacial prosthetic fellows this year. A little about myself. I'm a New Yorker, born and raised. I went to UConn for dental school and University of Maryland for my graduate prosthodontic training. My interest in maxillofacial prosthodontics stems from something one of my mentors used to say, that everything you study and learn only adds to the toolbox of skills you can offer your patients. Maxillofacial prosthodontics, though, I quickly learned is all about thinking outside of that box to brainstorm creative ways to treat patients, allowing the provider to restore the patient's quality of life in the wake of a life-altering experience such as cancer. Today, I'll be presenting two cases for a unique procedure which is only done at Memorial Sloan and Kettering Cancer Center that I had the privilege of being a part of. Today, there are many forms cancer therapy takes. They can range anywhere from older modalities such as surgery, which attempts to physically excise tumors, while newer modalities such as immunotherapy attempt to use the body's natural defenses to attack and destroy the cancer. The therapeutic treatment I'll be discussing is a combination of surgical extenuation and implant brachytherapy for patients with recurrence of orbital rhabdomyosarcoma. This therapeutic technique was proposed and perfected by MSK's very own Dr. David Abramson, chief of the Ophthalmic Oncology Service, and was actually published as well in the Journal of Prosthetic Dentistry. The whole concept of this technique is that patients with rhabdomyosarcoma are nowadays often treated with combined local radiation and systemic chemotherapy, which has a greater than 85% overall survival rate. The issue is when there's tumor recurrence after any of the previous modalities, which is rare, but often very lethal. Surgery does not completely remove all the malignant tumor. Radiation portal delivers unacceptable radiation doses to the brain, and chemotherapy has rarely been successful after external beam radiation. Therefore, the idea of the presented technique is the surgery encompasses a macroscopic resection of the cancer, followed by brachytherapy, which delivers an adequate therapeutic dose to treat the microscopic remnants while sparing surrounding healthy tissue. The two patients I'll be presenting are patients D and A. Patient D was a 22-month-old toddler when he first presented to MSK. At 4 months of age, he was diagnosed with stage 1, group 3, intermediate risk alveolar rhabdomyosarcoma of the right orbit. He had completed chemotherapy in February 2021 and radiation in September 2020, which is proton therapy, receiving a total of 5,040 centigrade with a complete response. Unfortunately, September 2021, the patient was noted to have a local recurrence. Patient A was a 3-year-old toddler when she first presented to MSK. At around 2 years of age, she was diagnosed with stage 1, group 3, intermediate risk alveolar rhabdomyosarcoma of the left orbit. She had completed chemotherapy July 2021 and radiation therapy in June 2021, receiving a total dose of 4,500 centigrade with a complete response. Unfortunately, in November 2021, the patient was noted to have a local recurrence. Both sets of parents discussed with Dr. Walden from radiation oncology and Dr. Abramson from ophthalmic oncology the multidisciplinary approach to managing orbital sarcomas with surgery and brachytherapy and agreed to treatment. Both patients underwent exoneration with Dr. Abramson, which is a surgical procedure involving removal of the entire globe and its surrounding structures, including muscles, fats, nerves, and eyelids. Patient D underwent surgery in November 2021, and patient A had surgery in February 2022. After the exoneration, an impression of the surgical defect was made using medium polyvinyl siloxane. Because of the undercuts present within the orbital cavity, a 3-piece impression was made. The first piece of the impression, once set, was removed and indexed with a pineapple-shaped striker burr and coated with mineral oil to prevent sticking to the next piece of the impression and placed back into the orbital cavity. Then a second piece of impression was made and then removed, indexed with the same burr and coated with mineral oil and placed back into the cavity. Finally, a third part of the impression was made over the first 2 pieces and captured the bridge of the nose and the orbital rim. An arrow was made with indelible ink to indicate the superior portion of the impression. All pieces were then removed and the defect was inspected for excess material. The area of the tumor was marked with indelible ink on the impression. The impression for patient A was done in a similar manner to patient D. After the pieces of the impression were reassembled, they were then taken to the lab and poured in Dikene. The brachytherapy device was then waxed up in baseplate wax and processed into clear heat polymerized polymethyl methacrylate. The greatest difficulty came when trying to figure out how the device with such a massive undercut would be able to be inserted. Margie came up with the brilliant idea of sectioning the device into separate pieces, allowing for better flexibility for the path of insertion, and then indexing those pieces with a cover to reorient their positioning, since the sectioned pieces would have space allowing play between where they were sectioned. On the left, you can see the undercuts that were present, not allowing a single path of insertion of the device. On the right, you can see how the cover indexes the sectioned pieces to keep them in position when separated. Catheters were added with pattern resin, which by putting them closer together provided radiation oncology with more options to choose from for where they could place the radiation sources, even though they didn't end up using all the catheters. 1 week post-surgery, the brachytherapy device was positioned and radiation treatment administered. The brachytherapy radiation source is iridium-192. In the old days, low-dose seeds were used that stayed in for 3 days straight. Nowadays, a fractionated high-dose rate approach is used, allowing more control over the dosimetry, and the child isn't radioactive all the time, which makes care for the child easier. In high-dose rate treatment, an afterloader is used while being monitored from the outside the operating room. The source is secured to a wire that travels inside the catheters and remains at specific locations during specific set times, normally seconds or so, for delivery of a total dose of 30 gray in 6 fractions. The total duration of treatment was about 5 to 10 minutes for each fraction. 2 fractions were delivered at 8 a.m. and 1 p.m. each day during 3 consecutive days under general anesthesia. The brachytherapy device stayed in the patient over the course of the 3 days and was covered in between treatments to prevent displacement. Based on the dosimetry maps, you can appreciate how high doses of radiation were able to be delivered with a very tight control of exposure when moving out from the area of intended treatment, allowing sparing of adjacent vital structures. The success of this technique has been 100% tumor control, even though cosmetic deformity from the surgery is significant. The biggest complication from the brachytherapy has been wound healing takes a very long time. As I'm sure anyone in this meeting can attest to, working at Memorial Sloan Kettering is truly an honor and humbling experience to be a part of a team that spearheads and perfects groundbreaking procedures that can really change the course of a person's life and leave them hopefully in a disease-free state. These cases are prime examples of truly thinking outside of the box to help achieve those goals of being able to call a patient disease-free. And that's it.
Okay, I guess we can now unmute for questions.
Actually, we have Dr. Singh.
Oh, I'm
Dr. Singh has
sorry.
a presentation
Dr. Singh.
too. Yep.
My apologies. Yes.
One more
Dr.
presentation. Yep.
Yep. Okay.
Thank you.
Screen. All right. A very good afternoon to one and all. My name is Anu Singh, and I'm a clinical research fellow at Dental Service, connecting with you from the other side of globe. It's 12:15 a.m. here, yet I'm so thrilled to have this opportunity to be a part of the Dental Alumni Meet 2022. And a little about myself. Having worked as a dental oncologist at a comprehensive cancer center in India, I moved to US in 2019 to start my research career and training at MSK. So of the many projects that the department which is going on, I choose today to present before you my most favorite topic on proton radiation therapy and dental dosimetry. So over the last few decades, significant improvements have been made in radiotherapy for the treatment of head neck cancer, from cobalt-16 machines to linear accelerators, from two-dimensional techniques to intensity modulated radiation therapy, from X-rays to particle therapy, etc. Radiation therapy with charged particle protons is now being widely adopted for management of head neck cancers because of this dosimetric advantage. And what is that? So the protons deposit the bulk of the radiation in a highly confined area called as Bragg peak. As such, the localization of the Bragg peak within the tumor will result in the minimal or no exit dose to the healthy adjacent tissues and causing less toxicity. So this is a good news for us. So this figure shows a post-operative radiation plan for a patient for squamous cell carcinoma of the left tonsil. And this photon and proton plans, they show how better sparing of the anterior oral cavity is achieved with proton therapy as compared to the photon therapy. And here you can see the parotid glands and the other organs at risk are also being spared when a proton therapy is used. And this table shows the direct comparisons of the photon versus the proton toxicity in the head neck cancers, defining the benefits of proton therapy in head neck cancers. And this unique advantage of conformality and Bragg peak has widened the therapeutic window for many head neck cancers. And that's why it's being now widely used for unilateral head neck radiation, oropharyngeal carcinoma, nasopharyngeal carcinoma, sinonasal carcinoma, skull-based tumors, and re-radiation cases. So at MSK, earlier patients were referred to the proton facility at New Jersey, which is Procure's proton center. But now that New York State has its own first proton center at East Harlem, all patients from MSK are frequently being referred for the proton radiation. While there are several ongoing clinical trials investigating the proton therapy in head neck cancers, we at Dental Service are currently looking at the rate of osteoradionecrosis of the jaw following proton radiation therapy, and which is one of the most, as we know, is one of the most debilitating condition which can affect the quality of the life in head neck cancer patients. So currently there's a very sparse literature on ORN with only very handful studies which have reported a very low rate of ORN, as you can see here. And this is a good news again for everyone. In the retrospective study based on 584 patients with oropharyngeal cancers, comparing the mandibular dose with ORN, mandibular dose and ORN in patients after IMRT and proton therapy, it was concluded that mandibular doses were found to have lower doses, and the ORN rates were also lower, where at 2% in 2% with proton therapy versus the 7.7% in IMRT. And another similar study from our very own dental service, it showed that the mean radiation dose to the contralateral regions were lower in patients with proton therapy as compared to those with IMRT. And this study revealed also that effectively there was an effective tissue sparing capability with the proton therapy. So this figure on the left shows the dosimetric distribution of mandible in the left base of tongue. And as you can see, the contralateral mandible has received negligible or zero dose. Similarly, on the picture on the bottom right shows the dosimetric distribution of the mandible in right parotid gland tumor, where the mean radiation dose on the contralateral side is negligible to zero. So the use of proton therapy has the potential to reduce ORN on the contralateral side. But what about the ipsilateral mandible side? So it's all about the RBE. So what is RBE? It's a relative biological effectiveness. So equal doses of different type of radiation do not produce equal biological effects. That means 1 gray of proton will be more than 1 gray of photon to produce the same biological effect. So for patient treatment, a constant RBE of 1.1 is currently applied for proton beams. That means 1 gray of protons is equal to 1 gray of photon, 1.1 gray of photons. This also means that proton will result in approximately 10% of biological damage per unit of physical dose than photons. So now I present some quite interesting cases that we have come across in our clinic. First case is of a clinical ORN which occurred in the ipsilateral mandible. So this is of an 87-year-old female patient diagnosed with Merkel cell carcinoma of the left cheek and underwent a wide local excision of the tumor and reconstruction with the left rotational advancement flap. And she also received an adjuvant therapy of 70 grays in 35 fractions to the left face and neck and completed in October 2014. She was a former smoker and was a social alcohol user. She had a past medical history which was not significant for hypertension and diabetes. She was all well, clinically no evidence of disease for 44 months. And then she reported to the dental service with a complaint in the upper left jaw. The extraoral examination showed an area of abnormal area, symmetry of the face with concave cavity. And then the intraoral examination showed that the remaining maxillary teeth were mobile. Number 14 had root caries, and there was a retained root tip on tooth number 15. So patient was advised a decoronation and excavation of the caries on the remaining root tips, and she was also advised chlorhexidine mouthwash, pain medication, and gentle brushing on the area. After a few months, she reported back to the dental service where she had a severe pain in the upper left jaw. An intraoral examination revealed an abnormal left gingiva and exposed bone area measuring 2.5 centimeter into 1 centimeter in the maxillary left region. And this was her last clinical follow-up, and she was lost to follow-up because she developed a Reckman's disease. Another interesting case is of a radiographic ORN in a 33-year-old male patient who was diagnosed with high-grade mucoepidermoid adenocarcinoma of the left submandibular salivary gland, underwent 70 grays of 35 fractions with weekly cisplatin chemoradiation completed in January 2015. He was also doing well for 49 months, and then he reported with a huge facial swelling and severe pain with the history of existing from 2 days. And a panoramic radiograph was taken, and it showed an area of radiolucency around tooth number 18, and was diagnosed with radiographic ORN, and which at present, after 15 months, he was managed with conservative therapy with antibiotics, mouthwash, pentoxifillin, but it just progressed, and now the patient he's asymptomatic because of the pain medication and antibiotic, but because of progression of the disease, he is now being considered for a surgical management, a mandibular resection and reconstruction in coming time. Another interesting case is clinical ORN, which occurred on the contralateral side of the mandible. She is a 50-year-old female patient diagnosed with adenoid cystic carcinoma of the left heart palate and underwent a 76-gray radiation in 35 fractions completed in September 2016. She did have a history of diabetes mellitus, and she was, again, clinically, no evidence of disease was NED for 35 months. And then she complained, she reported to the dental service with the fistula drainage in the right maxillary edentulous area. Intraoral examination showed abnormal 2 draining fistula, which was present distal of tooth 6 and anterior of number 2 tooth. So this is a series of panographic radiograph which I have put together. So the patient was, when the patient reported to the dental service, it was initially thought to be an endoperial lesion for which an endodontic therapy was done for the tooth. But then eventually the drainage continued, and then a cone beam CT was done to evaluate the edentulous area, which showed there was a severe bone loss around that area. And it was, patient was informed that the drainage was not because of the, did not appear to be dental origin. And she was referred back to the surgeon for management. She finally underwent the debridement of the necrotic area with a surgical graft and buccal pad of that. And now that we have an access to the proton radiation plans at the outside institution, and they are shared by MSK, we are able to go in and contour the regions. So when we contoured, we saw that even the opposite side of her jaw received a higher dosage of the radiation, because of which the ORN might have occurred. So the take-home message is proton radiation therapy will see a wider adoption with clinical, technological, and biological advances in coming time, because it minimizes doses to the critical organs, decreases toxicities, improves outcomes. But ORN continues to be a clinical challenge in the setting of proton radiation therapy. Clinicians who are involved in the management of head and neck cancers with proton therapy should be aware of ORN. So as an international trained dentist, it truly comes to me as a blessing and the best wishes of maybe some patients who I have treated back in India, to be that I'm a part of MSK, without which I wouldn't have had this learning experience in proton therapy, dental dosimetry, and medical physics. And I wouldn't have been, and where I got a chance to meet the best people, had the best training, and had the best times of my life. Thank you.
Okay, very nicely done.
Thank you.
And again, that 10% difference in RBE is really important. You know, especially in that last case where it was 76 gray is really 83 gray. So it's that very high dose. So it's not unexpected to have ORN. So you know, the proton therapy is not the panacea that everybody thought it would be. Great presentations, everyone. Any questions? You can unmute yourselves, Dr. Zlotlo. You're muted. Still muted.
So I have a question.
Okay.
Yes, go ahead.
Okay. Sorry, I'm having a little bit of connectivity issues, so I apologize if this was already kind of covered. But going back to the presentation about the prosthetics for marsupialization of cysts, the point of the prosthesis is mainly to keep the fistula open for the marsupialization. Is that the point, or is it to also kind of, you know, span any edentulous, you know, regions that need to come out for the surgery? So if we can, I'd love some clarification.
It's basically meant to keep that opening patent, because prior to this, the areas were packed with iodoform gauze or some other mechanical, and they have to be changed daily. Whereas with this prosthesis, they basically wear it comfortably after, it's like wearing an obturator and a maxilla. Eventually the epithelium heals around that projection, and the opening remains patent, decompressing the cyst. And it's just been remarkable. Dr. Tunick and I have done a bunch of these over the past few, it's over a dozen now at least. And it's just remarkable. I still am amazed at how quickly things resolve sometimes. So yeah, it's basically to maintain the patency of the unroofing of the cyst.
Got it. Awesome. That sounds so cool. So you add the acrylic during the time of surgery to go into the
thereafter, so again, just a point of practicality, we try in the base or the base plate before the surgery, so we don't have to futz around adjusting the base plate post-surgically. So we know the base plate fits, and then immediately after the surgery, we add this projection into the opening to maintain it open.
I think
really cool. I've never heard or seen of a prosthesis like this. Really, really awesome to learn about this.
I think what you have to know is that we used to put rubber tubes, nasopharyngeal tubes, catheters, any kind of a plug, and we'd have to wire it to the teeth adjacent to the opening. So now this appliance, which is like an Invisalign, allows us to put something in and leave it there, and it's actually more comfortable in the long run.
Yeah, and
so
cleaner,
this is
a lot cleaner.
Oh yeah, it's very, very innovative.
I'll also say that we've perfected the technique. We're still dealing with some of our finest head and neck surgeons when they come to these cases. Kind of do it the old way. Say, well, let's open it up, let's pack it with iodoform gauze, and 3 weeks later we'll put the obturator in. And it's just the wrong way to do it. I'm just so sorry that there is not the cross fertilization of between our services, and the fact that we've really developed a very excellent kind technique.
Anthony, that's good. So in terms of how long do you leave it in? And do you
again, as you saw, we monitor it radiographically
every couple of months?
I mean, there was that one case at 3 months and it was done. There's other cases would takes up to a year.
Okay.
So it depends on the size of the cyst and basically the healing capacity of the surrounding tissues.
So do you think every 3 months you take a Panarex, Dr. Huryn?
Well, I wanted to, I would take a preliminary Panarex at 3 months. Okay. I mean, you don't want to over radiate them, but on the other hand, you don't want them to wear the prosthesis forever. And what everybody's surprised is as soon as they remove it, that the surface heals right up. So we've never had a problem. Patient discontinues, and within a week the gingiva is closed. So they have to wear it 24/7. But once it's adjusted and comfortable, it's just like wearing a retainer post orthodontics. So it's I think we've come up with sort of a clever idea to maintain the cyst opening and maintain hygiene and everything else. They can take it out to eat if they feel they can't eat with the prosthesis, but they immediately put it back in, and they do sleep with it. They literally have to wear it 24/7.
One question is the possible infection rate associated with an appliance that keeps the area open. Have you seen any infection associated with the appliance?
So again, it's if you are wearing it 24/7, the plug or the obturator portion of it basically prevents ingress of food. I mean, it's not a hermetic seal, but sometimes these cysts are infected, sometimes not. I don't think we've ever seen an infection associated.
No, not at all. No.
Yeah,
But
Dr.
as it shrinks, patients are given irrigation syringes and
of course,
maintain it. And by the way, the more aggressive cysts or the non-aggressive cysts, it's all the same. They technique-wise, they shrink down, they mineralize. in the recurrent cyst, the keratodenogenic tumor. When you marsupialize them, the recurrence rate drops considerably. So it's really it's good.
Which is, that amazes me too, because the OKCs are always recurring, and we haven't had one recur yet. So it's really crazy.
So I think the hardest thing we face is convincing the patient to accept this treatment, because it just seems too easy. Most of them come to us having seen either other oral surgeons or head and neck surgeons, where rather major surgery was planned for them and so on. And we say, hey, no big deal. We're just going to open it up, put a little peg in, and you're going to be fine.
And the thing is, it's totally reversible, so you don't burn any bridges by doing this. So, I mean, God forbid, there was a problem, well, you'd go back to the big resection anyway.
Yeah.
But we've saved a lot of mandibles this way. Oh, we have.
So you're saying
the original research project was going to be doing a case series. So we had about maybe 7 or 8 patients that we have done this on, and I went back and looked through all the history and notes and everything, and not one of them had problem with infection or anything like that. The only thing they had was, we have to adjust the prosthesis from time to time because the cyst cavity shrinks. So we just have to kind of reduce the size of that extension sometimes, but no infection or anything like that.
Dr. Z, I think you're finally unmuted.
I'm on mute.
Yeah,
Can you hear me?
We can hear you.
We can hear you.
Great presentations. Yeah, we're so sorry about Dr. Strong. There was time in early 1988, he was doing a very big cyst removal. I think Jerry and Steve might remember this. And we were talking about instead of using the iodoform gauze, to use the dental compound, which I was familiar with in 1970. We used it for split thickness skin grafts, augmentation, for mandible augmentation. And we bury the skin graft for 2 to 4 weeks. And nobody got infected, and it maintained the graft. So this is an innovative way. You guys have really come very far. And I really appreciate everybody's presentation. You got sharp people, Joe.
Yes, we do. We're proud of all of them.
Thanks, Z.
One quick question for you. Oh, is the
I'm on mute.
Go ahead.
One quick question for you, Dr. Halpern. So how often, when do you use the irrigation? Do you do that after meals or don't even bother? What do you think, Dr. Huryn?
Well, I have them irrigate every day, sure, after every meal.
Every day.
But the thing is, they can't leave the prosthesis out for any length of time.
Right, okay.
So if they're eating without the prosthesis in place, of course, they have to irrigate immediately afterwards.
Okay, all right, thank
if they're
you.
wearing it during most of the day, irrigate before bedtime so that you're going to sleep with a clean wound.
Great.
Okay.
I'd like to say one last thing from me anyway. This has all been really terrific. And I just hope now that COVID seems under control and that next year we'll be able to do this in person again, like we used to.
Yeah, actually,
I was chatting with Dr. Lee, and basically intent was actually to have it at Coke this year, but I don't think we're ready for that just yet. I mean, Keith can talk to that later on. Yeah, we wanted to show off Coke, and there's a nice conference facility there that we could use. So hopefully next year, God willing, we'll be able to meet in person, and you'll get to see Coke.
Actually, yes. And before we get to Keith's closing remarks, we do have one question that we'd like to just answer before we move on. And the question is, any advice from past fellows or current fellows for a future fellow? Anything you wish you had concentrated more on, or something you should definitely focus on during the fellowship?
Investment banking.
Who said that?
Buy low, sell high.
What would you, any takers
I
from,
like that question.
any prior fellows, which is practically everyone here, and any current fellows, if you want to take that question. Hey, Dennis, any thoughts, comments, any advice for a future fellow, what they should focus on? Any takers out of everyone here?
I would say take advantage of every opportunity that you can to see any case, to collaborate with other services, and just seize the opportunity and really try to just be a sponge and soak up everything that you can, because you'll be amazed at how much what the first year out, the amount of information that you're gathering and where you can receive that is not even comparable to MSK. So that would be my only advice.
I would echo that. I think being at MSK, the opportunities to work with other departments and the amount of teamwork and camaraderie within the institution is something to take advantage of. Everyone is just so giving up their time that I think once you get out, you realize that not everyone is so giving of their time and energy to helping mentor young clinicians.
Dennis.
Hey, Dr. Andeza. Good to see you, man.
Nice to see you, everyone. I mean, one thing I want to echo is that the relationship doesn't end when your fellowship ends. And we all get very busy, but we all share this common interest and shared experiences that I feel like once a year may not be enough. So if anybody out there is interested in having, just like sharing your patient experiences and cases, and whether it be something that is challenging or something you're very proud of. And we also welcome any research collaborations for those of you that work in institutions. There's so much going on, and I value relationships more than many things. And I think that's
Yeah, I think all past and present fellows, attendings, residents, Steve will tell you, we become a conduit for referrals from our referral patterns, from our family, from our friends. So, you're kind of construed as an oral cancer expert coming out of this program, more so, and I'll tout MSK every day of the week. So I think that's something that you carry with you forever. And so you always maintain your contacts. And like Jerry said, I'm working on a case with my clots right now. I hear from former fellows with questions, or if they're close to New York, we work on cases. So the most important thing is just always keep your ears and eyes open, keep learning.
I have to echo that. I mean, we have this sort of loose association. I'm going to steal a little bit of Keith's thunder here. Please join the Alumni Society. We get calls all the time. Oh, I need a maxillofacial prosthodontist on the West Coast. I need somebody in Florida. I need, if we don't have your up-to-date information, we can't make the referrals. I mean, I get calls from former fellows saying, gee, this is a really difficult case. Would you mind seeing the patient? And again, we will refer to our fellows on the outside. And not only that, but knowing your co-fellows in terms of the head and neck people, very valuable contacts, because a lot of these people go on to academia or institutional practice. And I'll get a call from out west saying, I need a memorial trained maxillofacial prosthodontist. Or dental oncologist. And, as everybody sort of echo, you don't realize what you've learned until you leave the institution and say, my goodness, it's all of this information we throw at you. And again, both fellowships are just 365 days long, so you have to make what you can out of it. Make the connections now, and in the future, again, as Dr. Lee and Dr. Where are you?
Leg.
Leg. I don't see your picture on here. As they said, you know, you
leg.
sort of have to market your skills and your abilities in that regard, because you're definitely, you know, head and shoulders above any general practitioner on the outside, you know, no matter what their experience has been with the local institution. So please join the society. And again, on that note, Keith, take it away.
Thank you, Dr. Huryn. Yes, so hi, everyone. Thank you again for joining the meeting today. My name is Keith Yearwood. I'm the manager of the Alumni Affairs Office. I will be brief. I just want to make sure that I share some information with you. I want you all to be aware that today's meeting was recorded, and it will be shared with all of you at a later date, maybe in a couple of weeks. Also, CME is offered for this course, so please make sure that your email addresses are up to date. The CME office will be in contact with you through an email with directions on how you can claim your credits. And to echo Dr. Huryn's words, yes, we're all looking forward to being live in person in 2023, and we hope to be at the Koch Center. We have already reserved space at the Koch Center, so I mean, we're on target. We're making sure that we've done our due diligence, and we should be a go for 2023. Let's just keep our fingers crossed that nothing comes up. And
tell them what dates, so we all put it on our calendars.
Yeah, we have it posted.
March 21st, is it?
Yeah, I'll share my screen. It has all the information that everybody's talking about, including what you mentioned about. So here it is. Let me just put it up so everybody can see.
There you go.
Yeah, there you go.
So yeah, that's March 17th of 2023, and we look forward to being at the Koch Center. So it is very important that everyone shares their current information with us for all of the reasons that Dr. Huryn mentioned earlier. We want to be able to share your information in case you might have referrals. All of that is very important to MSK so that we can maybe forward patients to you in your area. So please update us with your current information and keep updating us so we can send you emails and keep you updated as to what's going on here at MSK and in the dental department. So thank you very much. And I'll turn it back over to Dr. Yang.
Yeah, thank you again for such a wonderful presentation, for all the speakers that prepared. It's really amazing. And I think this is a great way to keep in touch and stay connected and network together. And as Dr. Huryn and Keith mentioned, please send us any updated contact information so we have the most updated list. I have to say, for myself, I do refer almost like every single day. I will patients are looking for dentists, and I will give a referral list. And we would love to add you to that list so that if the patients need a dental provider, they can reach out. Our list encompasses contacts, from all the states. We have contacts in Florida and upstate and everywhere. So it would be a wonderful opportunity. Please contact us. You can contact Carlene, whose email is listed over there, so that we can add you to the list. If you have any emails that you want to update, please do that. And if you have any recent news or photos, we're really trying to kind of gather it and have it more centralized and organized. So I think next year we'll have more photos to share. And I think it's wonderful to hear of what everyone is doing, what they're up to. And as Keith mentioned, you will get an email for all of those people who signed up. You get an email from CME. You just need to complete a short questionnaire, and you will be able to get 1.75 credits. These are not dental credits, they're medical credits, but I do know that New York State accepts them. So speaking from personal experience, when you get audited and you submit the credits, they do accept. So I know it's good. And as they both mentioned, we have already booked our time and date for next year. And hopefully it will be at this Koch building. So thank you everyone for joining. If you have any questions, don't hesitate to reach out to us. Hopefully we can continue this tradition and stay in touch. Thank you, everybody. Now we'll just open up the time for everyone to catch up.
And I just, as an aside, I'm president of the American Academy of Maxillofacial Prosthetics this year. So all the MaxFace Fellows, please attend in person in Austin, Texas in October. So you'll be getting announcements as to that as well. All right, let's go back into gallery view, I guess.
Yeah,
So,
let me just,
yeah.
let me take out, let me pause, stop share.
There you go.
Yeah. Well, good to see everybody.
Yes.
I see Andrew and who else? Jen.
Jen is ready
over
for it.
there. Hey, hi everybody.
Dr. Kronstadt, where are you? Oh, there you are.
In my lair, in my office lair, you know.
All right. Hey, Andrew, there you are. How are you?
Good, how you doing, Dr. Halpern?
Yeah, everything down south is still there?
Yes. Well,
that's great. Good to see you, Ryan. Nice presentation.
Very nice, both of you.
Really enjoyed it. I'm really proud of all the fellows that have worked with me over the years, and it's so humbling to see how well everyone is doing. And it's really one of the highlights of my career, kind of seeing everyone grow.
Is
And
anybody here that was with Arvind Kadanpur?
who was with?
Who?
I have a photo of his graduation.
Who was with Arvind?
Who was his
Yeah, Arvind is.
Meriton was here, but that was like Dr. Meriton was with
Ahmad. Ahmad's not on.
Yeah.
His birthday today.
Yeah.
Right.
So Arvind is prosthodontist up at the new dental school, Toro College of Dental Medicine in Westchester, and I work with him. He's as busy as beans, and he's really making him proud. And I think we're going to get him working as a MaxFace prosthodontist, maxillofacial at Westchester County Medical Center, because now the school is linking up and they don't have anybody who's trained as you guys are. So that's just to let you know there's a future out there.
Well, I want to welcome Dr. Machinsik, who's joining us, and she is our incoming fellow. So welcome, and it's so happy to see you.
Hi,
Welcome,
thank
Jenna.
you so much. Hi. Yes, this is a great experience.
Thanks for coming.
Thank you. Thank you for inviting me.
Yeah.
This will be you next year.
We'll scare you off, but you get a taste of what's coming.
Yeah, it's great. I can't wait.
You're gonna have a blast,
Yeah.
This is for Lydia and Ryan. You know, this is more of a Boston thing. I have quite a bit of experience with the Brigham and Women's and the General and so on. And I'm so happy you're carrying the flag of memorial, you know, into that setting. They need it.
Yeah.
All right, and anything we can do to help, I mean, don't hesitate to ask.
We're also happy to speak to your GPR residents, Dr. Lee.
Oh, sure.
Ryan, if you ever have anybody that might show an interest in dental oncology, they can come and shadow us. We can, you know, Dr. Penning is I keep talking about presenting to her GPR, you know, program from last year, and I think it's something that I'd like to do in some capacity is, you know, give a talk to a GPR program or even Max, you know, a prosthodontist to just kind of showcase our fellows, let them really show your residents what they're doing. Because I've yet to see a fellow who did not like their fellowship at MSK. It's the other end of the spectrum. It's really, you know, it's really been tremendous, you know.
Yeah, actually, I think it's amazing opportunity. I actually invited our GPR director, Ryan, and we went to Jersey City Medical Center at different years, but and so I don't know, Ryan, if you saw Dr. Rotunda actually joined for your presentation.
Oh, that's nice.
Yeah, so and I kind of
Really
wanted
nice.
him to also see, you know, what, you know, like his former residents, you know, have gone into, and I think it's good opportunity for them to kind of see that for these residents, if any of them are interested in dental oncology, they could also, he could, you know, help guide them our way so that we could, you know, have them join us as well. So I think it's a great opportunity.
Yeah, and don't forget, you know, always pay it forward. Teach what you learn.
Yeah.
Never ends. I'm always learning from our fellows and residents.
That's true. They
Always
keep us on
learning.
our toes.
Yeah. They keep getting smarter and smarter every year.
Yeah. It's scary.
Well, you know, it's amazing. In 1 year, it's a lifetime education. Those 365 days are packed, and you're learning a whole new venue of treatment management of a small population of patients. Amazing.
One thing you can add in that photos, Dr. Yam, is the wedding of Dennis Shem, where Ed was his best man. So that's really,
Oh yeah.
that's really cool. So let's put that in next year.
No, for sure. We didn't get a chance to be very inclusive with the photos, but I am gathering all the photos. Congratulations, Dennis. Your wedding photos were amazing, and you know, it would have been hard to pick one or two.
I mean, I can pick and send one or two.
Would you, if any of you have any photos to share, please forward them my way. I am going to try to catalog by year, and we'll have them kind of scrolling. It's kind of nice to see how everybody has changed, and I never saw Dr. Tudyk and Dr. Halpern like from way before, and it was amazing to see their older pictures. And when Dr. Stillo was a resident, actually a fellow when you were a fellow.
Yeah, and the picture of the holiday party where my 14-year-old was like a 2-year-old. I was like, oh my gosh.
I know. I couldn't believe that was Evelyn. Yeah. So cute. Yeah.
And just like seeing Ryan, and like Ryan did the contouring 10 years ago.
Yes.
And now I knew it. So we have like, I don't know, like 1,000 patients with contours since you did it, Ryan.
Are we still contouring?
Yes. Sure. We have a database. We have a nomogram. We have a whole thing. Yeah.
I still dream about contouring sometimes.
You got to come by.
Yeah,
we can have Anu show you.
Yeah.
I mean, Ryan, we have really incorporated the contouring into our practice. I think when you did it and when, Heidi was doing it, it was sort of new, novel, and a few, it was for research purpose. But now we do it for every single patient. Anybody that comes back and needs some dental counseling, we contour right away, and we're able to tell them like this dental bearing area received whatever it is, 5,400 centigrades, and we make our recommendations, partly, that's a big part, in our recommendations. So it's become like our, part of our clinical practice. So that's really like, I think the earlier contours like you and Heidi.
Really, we still have it. It's on the big database.
Yeah, it is. Yeah.
Yeah. So that's part of the legacy.
Yeah, everybody builds on everybody. So
it's a total game changer for me. Totally. All my decisions are based upon that. And before it was a nebulous decision. So great game changer.
Actually, a couple of years after I left, when I was still teaching at NYU, I was a part-time attending at New York Methodist Hospital in Park Slope. And I sort of kind of taught them the contouring thing. And they actually have a radiation oncology residency program. So I believe they're doing it. And so they know clearly that this is an MSKCC thing. And it just makes me feel so good inside that this is something that's been incorporated. But I'll also say that probably 99% of dentists still have no idea what that contouring might be like. And so what a wonderful service that you can add to any sort of dentist that's dealing with a cancer survivor. Unbelievable.
Yeah.
I got a call from Mount Sinai. I was dealing with a head neck patient, and I spoke to the radiation oncologist, and I talked about contouring. He knew about it, but then he said, is there anybody I could call at Memorial to discuss it? So they're not really doing it at Sinai.
They're not really doing it anywhere. I mean, it's seldom that you'll get contours from an outside institution. It's very, very rare. They sort of get it, but they don't really do it, and so you'll get the wrong slices, you'll get the wrong, so we just had one the other day, and they took the time out to do these contours, but they didn't contour through the teeth. So, what use?
Yeah.
Anyway, it's good to see all of you.
Good to see everyone. Andrew, how's everything down in the South?
Going well, man. I'm enjoying my dad's practice. We probably see 2 to 3 oncology patients a week now.
Oh, wow.
Nice, Andrew.
Great.
Wow.
I actually gave us a C course at the University of Alabama Dental School about a month ago. So I did an oncology presentation for them. So
sweet.
Good for you.
Fantastic.
Great.
Hey,
How
don't
about
give
you,
them all
Dennis?
information. Don't tell them everything now.
Yeah, proprietary.
Right.
How's oral path?
It's been good. Yeah, learning a lot.
Yeah.
Yeah, it's been really good. Yeah, and I think it's also been good to be able to share. Yeah, exactly the information that I've gotten to hear with the pathologists and dental students at my institution now.
It's fantastic.
Yeah.
Which Jenny, I've sent a few patients your way to in Florida. I don't
Same
know if they
here.
ever
Yeah.
made
Yeah, I
their
sent a
way to
couple.
you.
Yeah.
Yeah. I don't know. There's been a lot of Florida patients looking for a local provider once they go back and after finishing treatment here. So I don't know if you saw anybody from here.
I spoke to a lot of them on the phone. Some of them don't necessarily need someone just yet. Doctor, you're in my patient from up there. I spoke to her on the phone. She didn't need me, but we coordinated some of her endo treatment. When I was hired, they told me maybe 1 or 2 max face patients a month. It's definitely 1 to 2 new max face patients a week and growing.
Oh.
I made friends with a new head and neck surgeon down here, and then he's convinced this is practice to refer to me. So that also goes for the radiation and the dent onc too. So I'm doing less conventional pros and more max face pros than I planned, which is great. I was not expecting to do so much. And I'm definitely sharing a lot of that knowledge with everyone's general dentist as the patient.
Wonderful.
So
it's great.
Very
Good
great.
job.
Obviously the MSK name is, a big glowing halo around my name. So I appreciate my time at MSK for all of that.
Killing it.
Great to see you.
It's wonderful.
Hi, my name is Paul Conradi, and I had the honor and privilege of going to MSK back in the 80s with my fellow classmate, Dr. Joe Randazzo. And we had a great time, and I had the honor and privilege of working under Dr. Huryn and Dr. Zlotlo, who I saw earlier. And I don't know if Dr. Randazzo is still in the background there. I saw him in the background with someone. But, I could say I have to give a shout out for the, quality of the fellows that you have and the presentations that you put on today. So I'm really very impressed. And I can say that one of the things that MSK has done for me is really opened a lot of doors. I'm in the Midwest, out in Milwaukee, where it's very cold, and sometimes they say the men are men and the cows are scared. But it's a great place. But coming from MSK, I was very privileged that there was only 3 maxillofacial prosthodontists in the whole state of Wisconsin at the time when I started. And I taught, full-time at Marquette University, and I was on, appellate team at Children's Hospital and head of craniofacial at Frederick Hospital in Milwaukee. But it allowed me to be able to get referrals from all over the state of Wisconsin, Illinois, Michigan, Minnesota, and so and Iowa. And so it was a great thing. And you're going to find that when you get out, just coming from the institution of where you just finished your training or going to be finishing your training this coming summer, it's going to really open a lot of doors for you. And so, my compliments to Dr. Huryn and I don't know the other people that are, running the residencies for the oncology program, but you got a really good quality group of students that are, I should say, fellows in your group there. So congratulations.
Oh.
Dr. Conradi, I didn't know they were growing palm trees in Wisconsin.
Well, actually, I'm on the witness protection program, so they shipped me off to an island. It's been a number of years. I've been retired now for about it'll be 22 years this summer.
Wow.
At the end of the summer.
You better talk to Randazzo.
Yeah. Yeah. Oops. Silence that. I have to say, Joe was great. I don't know if you guys, sounds like you all had a chance to work with him, and but
still do.
Yeah. So
he is great.
When Randazzo and I were in the program, Joe's motto was "the bloodier, the better." When it came down to in the OR, you know, we'd get there and he'd roll up his sleeves and he'd go, oh, you know, we're gonna, you know, and so we had a great time. It was a great learning experience, you know, with Dr. Huryn, Dr. Pirro, you know, Dr. Lotlow and Rosenberg, and it was great. So you know, I think you guys are well trained and you're going to do great. You know, where you
Nice.
in the United States.
All right.
Thank you so much. It's nice to hear from somebody from Dr. Randazzo's class.
Well, they were my first residents. Joe,
right.
Paul, and Jennifer. What's her name? We had 3 Max Face Fellows. They were the first ones that we.
Jennifer Burrell, right?
Yes.
Right. Is Randazzo still there in the background or no?
I think he went to the OR again.
Oh, he did. Okay. Well,
Yeah, he still likes the blood.
Well, I saw Ian earlier. I don't know. He must have. I don't see him on board anymore. But I have to, you know, thank Dr. Randazzo for saying the nice, kind words at the last meeting about myself, and he went on and he read it exactly like my mother wrote it for him. And so, you know, I did get a chance to watch the last alumni meeting. And I thought the presentations were phenomenal then. And I thought, you know what, I got to sit in this time. I'm going to, you know, chime in and actually show my face. So don't tell anybody else in the government where I'm at.
Well, we'll see you next St. Patrick's Day.
That's right. And I hear they're going to be having Guinness and corned beef and cabbage. Is that correct?
Absolutely.
All right.
We're going to have to somehow incorporate that into our cocktail time.
Yeah, really. The only hors d'oeuvres I had today were pretzels. I don't know.
Okay, guys, I guess we should close.
Yeah.
So nice to see
Thank
everyone.
Nice to see everybody.
Thank you so much.
Really.
Nice to see everyone.
Thanks for coming. Thanks for presenting. And we'll see you next year.
That's right. Everybody be well, stay healthy.
Take care.
Take good care. Really nice to
guys,
see
good to see you all.
everyone.
Thank you.